night, everyone. Hi, welcome to our event this evening. Welcome, everyone. Thank you for taking some time out of your day to join us. We're very excited that you're here. I want to introduce you to Sister Give Me Your Hand. Before we get started with the talk tonight, we're going to be speaking about different changes that can occur in your breast and which ones are cause for concern and can lead to breast cancer and which ones are normal. Go ahead, Pasha. Okay, thank you again for joining us for the talk this evening. Quick overview of the agenda. We'll be talking about what Sister Give Me Your Hand is briefly. We're going to be speaking about malignant breast changes or breast changes that lead to breast cancer with Dr. Carter, and then we're going to follow that up with benign breast conditions or normal breast conditions that do not lead to, that are not cancerous with Dr. B. So just wanted to share a few facts about breast cancer with you. Breast cancer is the most common cancer in Black women, and Black women in the United States are about 40% more likely to pass away from breast cancer than white women. Also, Black women tend to get breast cancer at younger ages and also have more aggressive forms of breast cancer. So Sister Give Me Your Hand is a program that was created by Black women in medicine. The work that we do is with community and faith leaders, not only in Brooklyn, but in Camden, New Jersey as well. We work to connect Black women to breast health education. So important to know what are breast changes and the things that can occur as it pertains to your health, and then also mammography resources. So making sure that we connect people to places where they can be followed up for their breast health. Right now, we're actively working within the community, speaking to women in the community to get their feedback about what the process looks like when you do try and get breast cancer screening. We want to make sure that we can address some of the barriers that Black women are facing when trying to access care. So if you are interested in signing up for our survey, we do have 2 links in the info here and at the end that we will be sharing with you. So to start, we're going to have the malignant conditions that Dr. Teralynn Carter will be sharing with us this evening. And I want to introduce Dr. Carter. So Dr. Carter is a breast surgical oncologist at MD Anderson at Cooper University within their healthcare system. She completed her general surgery training at the University of Colorado in Denver. And she completed her fellowship in breast surgical oncology at Emory University in Atlanta, Georgia. She is interested in disparities in cancer care and is focused on improving outcomes for women, starting with screening and early detection. Please join me in welcoming Dr. Teralynn Carter as she discusses some changes that undergo some cancerous changes that can occur to your breast. Thank you, Dr. Carter.
Thank you, Frances. I am happy to be here tonight and hope that I can impart some knowledge upon you. So I just want to start with the basics. What is cancer? Cancer is an uncontrolled growth and spread of abnormal cells. When we see these, that's when you end up with a mass or something else that I'll talk about going forward. But I think it's important to understand the basics. Next slide. What causes cancer? There are a lot of factors. There are some that we can attest to internal things that happen in your body that you have no control over. So these internal factors might include hormones, immune conditions, or different genetic mutations that you have passed down through your family. That being said, most cancers in the breast are not caused by a genetic mutation, but we do want to look at patients to make sure that we're not missing something if we do see a cancer, especially in younger women. Some external factors that you do have control over yourself Are you a smoker? Smoking tobacco is a risk factor for new cancers, including breast cancers. Other things that could be factors contributing to the development of a cancer is poor nutrition. Chemicals in the atmosphere around wherever you are, where you're working. Radiation can cause cancers, and sometimes even infectious organisms. Next. Okay. So who is at risk for developing cancer? You've already seen some of the statistics about Black women and cancer, but frankly, anyone can develop cancer. The lifetime risk for women is 1 in 3, so about 38% of women will develop a cancer. And breast cancers occur in women, mostly in their 60s, to be honest, or older. About half of the breast cancers in women occur after age 62, and half occur before age 62. The thing about this is that not every cancer is going to occur at age 62. So we need to look at patients of all ages and make sure that we're adequately looking to see if we can detect a cancer in its early stage. As you've already heard, in Black women, breast cancer is often found at younger ages than we think of our average age in the overall population. Next slide. So why do we screen and treat breast cancer? I think it's important to know that there are more than 3.5 million breast cancer survivors living in the United States at this time. And if you were to be diagnosed with breast cancer, we want to make sure that you join that group of survivors and are not one of the people that succumbs to the illness. We also know that it is relatively easier to treat breast cancer when we find it at earlier stages. And how do we do that? We do that through screening, which I'll talk about going forward a little bit. But if you take a peek at the chart here, you can see that when we find cancers in a stage where they're localized just in the breast, we have a 5-year relative survival rate of about 99% for all patients who are treated in that stage. If the cancer has moved to the lymph nodes, then the survival decreases a little bit. And that's about 86%, which is still good, but not as good as it could be if we find things early. Additionally, we know that delays in care lead to worse outcomes. And there's data telling us that in Black women especially, there are delays of care for a variety of reasons, and it's my job to help fix that. Part of that is when I see patients in clinic, but part of that is also me being here tonight to talk to you about how we screen and find and treat breast cancer. Next slide. So what might you find on a breast exam? You might see a lump in your breast. You might see a new rash on your skin. You might have new nipple discharge that you didn't have before. There might be skin thickening, dimpling, or puckering, or a change in the shape or size of your breast. It's important that we encourage women to do self-breast exams because oftentimes, if there's something that is bigger than what we might just detect on a screen in between your screening, you might be able to find a mass yourself or notice changes for which you should go seek out care. So you can see here, I have a little picture of how to do a self-breast exam. So you might do it laying down or in the shower. It's important to try and do it at about the same time every month because your breast changes with your hormonal changes. And you put your arm up and make sure you feel around your breast in a circle, radially and up and down to try and see any changes. It's also important to note that I mentioned rashes or skin changes or a change in shape or size. And these are things that you might notice in the mirror. So it's also important to look in the mirror when you do your breast exam. But you might not be the one to notice something on an exam. You might go to your provider, your primary care, or a specialist for whatever reason, and they do an exam, and then they find something and send you on. So let's talk about what happens after we find something on a breast exam. First things first, you want to have an examination by a specialist provider. This may or may not happen before your imaging, depending on who has noticed an abnormality in your exam. So if you go and see a specialist provider, such as myself or Dr. B, you would find that the provider will do an examination of your breast and assessment of your personal history. We want to know what sort of extra risk factors you have above the general population that could lead to development of a cancer. Then we would proceed on to have you have imaging, which would include baseline mammography, depending on the last time you've had a mammogram. It could also include an ultrasound. And then once we can see what's going on in your breast, we'd move on to a biopsy. Next slide. So there are, as I said, a few modalities that we can use to look and see what is going on in your breast when we start with imaging. So imaging on the far right of your screen, you'll see a picture of a mammogram, which shows sort of an irregular mass in the breast. And below that in the middle, we also see calcifications. So when people are talking to you about what they're seeing on your imaging, these are sort of the key buzzwords that they'll be using. In some of these images, we can also tell if your skin is thickened, and we can say that things are irregular. The left-hand image is an ultrasound image of a mass that is a cancer. So we use all of these imaging modalities together, including MRI sometimes, to make sure that we're getting a full picture of what is going on in your breast. Next slide. So then you get biopsy results, and we want to look at what are they going to say to you. There are a few things that the biopsy results can say, and Dr. Bea is going to talk more on this first category in the second half of this talk. But one of the things that the biopsy results can say is that everything is benign and okay. There are also what we call pre-malignant lesions, and these lesions would contain what we call atypical cells. Oh, go back, sorry. Atypical cells. These lesions will often require surgery so that we can check and make sure that there's nothing hiding in them and that we can reduce your risk for a cancer in the future. And then the third category that we might find would be a cancer. Okay, next slide. When the biopsy shows cancer, we're going to be looking at a few things about it. And you'll see in this graphic that I have here, one of the things that we worry about is size. And often when I'm talking to patients and I'm explaining to them the size of what we're looking at sizes based on images, and they can be a little bit abstract. So most of the time things will be measured in millimeters or centimeters. Now we're used to dealing in inches, so millimeters or centimeters might be a little bit harder for us to visualize as to how big things are. So 1 millimeter, as you can see, might be about the size of the tip of a sharpened pencil, whereas 2 millimeters would be a crayon, and 5 millimeters, also known as half a centimeter, is an eraser tip, okay? So it's important to keep in mind that when we're talking about sizes, the numbers might be going up, but the sizes can still be pretty small. It's probably not until we get to about 2 centimeters or the size of a peanut, as you can see here, that people will start to feel masses in their breast. And that is why we screen, because we can often pick these out on screening. Okay. The next thing that we look at when a biopsy shows cancer is what we call biomarkers. These are 3 different receptors that we look for on the surface of a cancer to help us figure out how to treat you. These receptors would be estrogen and progesterone, which are sex hormones naturally occurring in the body, and HER2/neu, which is a growth factor that can occur on breast cancer cells. I think it's important to share this with you all because the terminology can get very confusing if you go into the doctor's office and all of a sudden they're talking at you about a pathology report. So these things, as I said, are 3 biomarkers that we use to kind of figure out what the best treatments are going to be for you. And then, as I mentioned earlier, it's important for us to know kind of where the cancer is. So location is the third thing that we think of when we're talking about what is going on with your cancer. As I mentioned, we know that when the cancer is in the breast, all comers have a 5-year survival of 99%. We talk in 5-year intervals because it's easier for us as providers to divide time in a way that we can count and tell people all the time. Whereas we don't want to tell you that a 5-year survival is your life expectancy. A 5-year survival is just the easiest way for us to divide things to be able to give you time periods as to how breast cancer happens. Okay, next slide. So let's talk about when we go to location of breast cancer. I just want to revisit these numbers. So if you look at this pie chart on the left, most patients are diagnosed with what we call a localized cancer, which is in just your breast. And the survival of that, as I mentioned on the right, is about 99%. If we wait to treat breast cancer or don't find it until it has spread to your lymph nodes, which might be in your armpit, or somewhere else in your body, then our ability to treat it goes down a little bit. We can still treat breast cancer and you can still live a very long life with it, but we do want to catch it as early as possible so that we can have the best outcomes possible. Also, sometimes happens is that people are diagnosed at a very early stage, but for whatever reason, there is a delay in them getting from the diagnosis to the actual treatment. That may be because you're not able to see a provider, or because you don't know where to see a provider, or you see a provider and then get lost in the system. And that's one of the things that we want to try and prevent partially with this program, is to make sure that you know how to navigate what happens after you have your mammogram. Next slide. Okay, so in summary, when we're talking about malignant changes in your breast, you should first, if you find a lump, don't panic. You're going to find out in a few minutes a little bit more about what happens with lumps that aren't cancer. And since not everything is, it's important that we always check and find out what it is so that we can make the best treatment decisions for you and you can be involved in your healthcare. But it's important not to wait. Get it checked immediately. We want to make sure that we have you treat it at the earliest stage possible so that you can have the best outcome possible. And sometimes when you get it checked, you'll find out that it is not a cancer and you just need a surgery or some other treatment that does not affect your lifestyle going forward. And lastly, I think it's important to remember that breast cancer is treatable and survivable. And at both of our institutions and many other places, there are whole teams available to help you navigate through this system. Thank you.
Thank you so much, Dr. Carter. Thank you again for teaching us a little bit more about some changes that can occur in the breast, leading to breast cancer. Now we're gonna have Dr. Bea take over. Dr. Bea is the section chief of the breast surgical oncology at Presbyterian Brooklyn Methodist Hospital. She also serves as the assistant professor of surgery at Weill Cornell Medicine. Most recently, she was a breast surgical oncologist in the division of breast surgery at MD Anderson Cancer Center in Cooper, Camden, New Jersey. And prior to that, she served as a clinical specialist at the University of Texas MD Anderson Cancer Center in Houston, where she completed her fellowship in breast surgical oncology. She completed her residency and internship in general surgery at the Medical University of South Carolina in Charleston. She's recognized as a rising star and top physician in her field. She was selected as one of the 40 under 40 leaders in minority health by the National Minority Quality Forum for her dedication to community outreach and breast cancer disparities research. She's also been recognized by the American Society of Clinical Oncology, Concord Cancer Foundation, and has received the American Association for Cancer Research Minority Scholar in Cancer Research Award. She's a member of the American Society of Breast Surgeons, the National Medical Association, the American Association of Cancer Research, and the Arnold P. Gold Humanism Honors Society of the American College of Surgeons. Dr. Bea is also the founder of Girls Loving Ourselves Successfully, a mentoring program for underrepresented middle and high school girls, and she's a children's book author. So everyone, please join me in welcoming Dr. Bea this evening as she discusses benign breast conditions.
Well, thank you for that fabulous introduction, Princess. So it is a pleasure to be here with all of you today. And Dr. Carter really started the evening out with some important information. And I think, we will focus on some of the main points that she discussed after my presentation, but I'm going to hone in on one of the most important parts of her topic, which is screening is so important. And that's why we have the Sister Give Me Your Hand. And with screening, we know from the community, from community women, I'm in Brooklyn currently, and I was in Camden, New Jersey previous to that, that we often fear what may be found. And I am a strong believer that knowledge is power. And if you understand what could potentially be found and what the ramifications of that are, then perhaps going to get a mammogram is not as difficult. So I'm going to discuss benign breast disease, and benign means non-cancerous. And believe it or not, when we discuss breast, we often talk about cancer in the breast, but the majority of breast lesions are actually benign, non-cancerous. Next slide. So we're going to briefly review breast anatomy. We'll talk about common breast complaints, screening and breast imaging, benign breast diseases, and some risk assessment. So this is I'm a surgeon, so I look at the breast with different eyes. So Dr. Carter, we've seen this before, but I often like to show it because when you think about your breast, all you see is skin, but there's a lot of stuff happening beneath that skin. You have, of course, your nipple, which is on top of your skin, but underneath that you have tissue, which consists of fatty tissue, and then breast tissue that's made of glands, and then fibrous tissue. You also have ducts, and the ducts are responsible for milk leading up to your nipple, and then lobules, which actually assist with milk production. And here's another picture, sort of an anatomy picture with the breast. And it's really just to highlight that oftentimes when we talk about breast disease, we also, as breast specialists, think about lymph nodes in the breast as well as underneath your armpit. And the technical medical name for the armpit lymph nodes are axillary lymph nodes. Breast development occurs during your teenage years and is really influenced by hormones. So estrogen and progesterone are absolutely important in the development of your breast. And then they're also, unfortunately, responsible for some of the cyclical changes that we have, meaning when you get your menstrual cycle, that can cause breast swelling, pain of your breast. So it's important to understand what the risk factors are. And I break the risk factors down between modifiable risk factors as well as non-modifiable risk factors. And these are risk factors that increase your risk of developing breast cancer. The main thing to think about this is just by simply being a woman, that is a risk factor because of the estrogen and progesterone exposure to your breast. That's something that you cannot change, so it's non-modifiable. As you get older, you increase your risk of developing a breast cancer. And so that's also not something that you can avoid. Estrogen exposure there are some ways that you can avoid or limit your estrogen exposure, which can then decrease your risk. Things that you cannot avoid as it relates to estrogen is when your period starts and when you go into menopause. But we do know that hormone replacement therapy, which is often offered when you're in your menopausal years, can increase your risk of estrogen exposure. Other modifiable risk factors are the age at which you develop, the age at which you I want to say develop, but deliver, thank you, deliver your first live birth. So the younger you are, believe it or not, you have some protection. Breastfeeding is absolutely protective. And I am, as I am sure Dr. Carter is, pro breastfeeding. So we encourage breastfeeding. Modifiable risk factors, obesity. So one of the things we often talk to our patients about and to the community is healthy eating habits, weight loss, because it does decrease your risk of breast cancer, but also other medical issues. Believe it or not, alcohol consumption also can increase one's risk of breast disease, and tobacco smoking does as well. Next slide. So I'm all about pictures. So I want to show you some pictures because we often say, well, come to us when there is a breast complaint. And it's interesting when I have patients who come in, they say, well, I mean, it changed, but I wasn't really sure. So knowledge is power. When you have an inverted nipple, and this is what a nipple looks like, that is a reason to come and see a breast specialist. And this is particularly true if you have never had a nipple that has inverted inward, and now all of a sudden you see that. Now there's a question that popped up. What if, I thought that said, what if you had it as a child? So if you had it as a child, then that's normal. But if you developed it later on in your years, then that's something you should seek attention for. And the first two pictures are the nipple inversion. The third is a normal nipple. Next slide. Signs and symptoms of breast disease also include a crusty looking nipple, which is illustrated by the first and third picture. And I point this out two different ways because oftentimes I hear patients come and say, well, my nipple got sort of itchy or flaky. Oh, can you go back? My nipple got itchy or flaky and I thought it was just a rash or eczema. If you've never had eczema before, this is not where it's going to start. Now, it could be eczema, but you want to see a specialist to prove it either way. The middle picture is what we call peau d'orange, and that is a fancy way of saying it looks like an orange, like a large orange, and that's actually a concerning sign for breast cancer. Next slide. We can also see nipple discharge. Now, if you are breastfeeding, milky nipple discharge is normal. But if you're not in your breastfeeding years, then bloody nipple discharge, milky nipple discharge, green, you can also see it brown. Those are reasons to come and seek attention. Now, I said that I'm talking about benign, but I'm kind of diving a little bit into the cancer because sometimes they're interrelated. We can see these nipple discharges and find actually benign lesions like an intraductal papilloma. So again, just because you have these signs and symptoms doesn't necessarily mean one versus the other, but what it absolutely means is that you need to come and see a breast specialist so that we can help figure out what's going on. Next slide. And Dr. Carter talked about some of the ways in which we look at your breast through imaging. Our three most common are through mammography, ultrasound, and MRI. Next slide. And we use these imaging modalities for different reasons, but the mainstay is mammography. And we do recommend that you start your mammogram at the age of 40, unless you have a family history of breast cancer, at which point you may be recommended to have your breast screened before the age of 40. And we do recommend yearly. Now, your physician may say, or your primary care may say, oh, you need to start at a later age. But most breast specialists agree unanimously that starting at an early age, at the age of 40, has shown benefit, particularly in minority communities. And I put this little caricature there because it does illustrate that getting a mammogram is not fun. I recognize that I've had a mammogram before, and it simply is not fun. But it's something that you absolutely should do, and it could potentially save your life, as Dr. Carter illustrated. Next slide. An ultrasound is another way in which we look at your breast. And illustrated to the right is actually a benign lesion called a cyst. And so the way that the ultrasound works is the tech will put some ultrasound gel on your breast, and we'll look for little lesions that may be present. And sometimes they recommend biopsying. Now, an ultrasound is used adjunctively if you have dense breast. So in New Jersey and New York, we know that when the breast imagers look at your breast, they will note whether you have dense breast. 50% of women actually in the United States have dense breast. And so an ultrasound should be tagged on along with the mammogram yearly. Next slide. And then an MRI is our third modality. We don't use this as a means to screen, but we do use it in certain instances for high-risk disease, meaning if you are found to have a gene mutation like BRCA, and for other reasons. Next slide. And so what if we find something? Well, if we find something, the next step is that we want to biopsy it. And we biopsy by different ways. We do an FNA, which is called a fine needle aspiration, or a core needle biopsy. You're numbed before anything is sort of removed and made comfortable. And then as you can see, this little needle goes into the mass and pulls the tissue, and then is sent to the pathologist so that they can look at it and let us, breast specialists or your primary care, know what the mass comes back as. Next slide. So let's talk a little bit about some of the benign breast issues that we see often. Breast pain, fibroadenomas, we'll talk about cysts, infections of the breast, gynecomastia, fat necrosis, fibrocystic disease, and then we'll briefly touch on high-risk lesions. Next slide. So breast pain is something that we all see and a lot of us have, but we don't often talk about. So I'm here to make it normal. I have breast pain. Breast pain is a thing. So if you have breast pain, you are not alone. In fact, if you ask every woman that you know, I guarantee you will find at least half of them have breast pain. So what do we do about breast pain? Well, breast pain, you want to sort of think about ways to decrease the pain, right? And while it can be true that breast pain is associated with your menses, that's something that you can't necessarily control. There are instances where breast pain is just consistent or persistent. And that's often due to caffeine or coffee. So that's something that most people don't know. If you decrease your coffee or caffeine intake, chocolate, teas, breast pain may actually get better. Smoking also increases one's risk of breast pain. Stress increases breast pain. And also your bra, you want to make sure, especially if you are heavy on the top, that you have a supportive bra that prevents your breast from hanging down, and that often can assist with alleviating the breast pain. I also recommend, in addition to decreasing your intake of caffeine, not smoking, not drinking, decreasing stress, to meditate, to drink plenty of water, and then also supplements like vitamin E can assist as well, and even primrose oil. Next slide. A fibroadenoma is one of the most common benign breast lesions that we see. It's a benign tumor. It most often affects young women. So your daughter may have a little palpable mass that she comes to you and says, hey, or your niece says, hey, this is here. Please take the daughter to get it checked out. Don't assume it's a fibroadenoma. Let us biopsy it, look at it with an ultrasound, look at it with the ultrasound first, and biopsy, and then decide whether it needs to be surgically removed. Next slide. Cysts are also very common, and they come in 3 different types: simple, complicated, and complex. Based on the type, we decide whether we just watch it with an ultrasound, leave it alone, or whether it needs to be biopsied. A cyst, the best way I can describe it, it's a thin-walled fluid structure. So it's in sort of a little capsule, and there's fluid there. And again, it's very common. It can also be associated with your cycle. Next slide. Mastitis or inflammation is very common and can be associated with not breastfeeding as well as breastfeeding. For the non-breastfeeding, it's actually increased due to smoking as well as obesity, but it's actually very common, and oftentimes patients will come into the ED and say, why do I have this? The mastitis, or the mastitis that then turns into an abscess or pus collection. And sometimes we don't have a clear answer. The treatment, however, is to alleviate or remove the pus, open it up, as well as start antibiotics. Mastitis also, I see in my clinic often women who are breastfeeding, and it's basically due to clogged ducts. We encourage massaging those ducts to help alleviate the clog and continued breastfeeding. Next slide. And this is the breast abscess that oftentimes the mastitis can lead to. And again, it's just the pus pocket that we have to open up. Next slide. And gynecomastia is hypertrophy seen in men. So this is actually a benign disease, breast disease for men. We often see this in men who have some form of maybe estrogen exposure, also associated with liver and liver disease, as well as testicular cancer. Not often testicular cancer, but that's something that we want to sort of rule out. Any reason that sort of hormones are increased in the male. So unfortunately, marijuana also contributes. So we're seeing an uprise in gynecomastia. It can be painful. I often say if you have a man in your life who has painful breasts, please send them in so we can evaluate them. We can get the proper imaging, and because males do have breast tissue as well, and breast disease. Next slide. So the pathogenesis of malignancy. I like this picture at the bottom because it sort of shows you. So remember I said at the beginning, your breasts are made of ducts, and then ducts sort of lead into, ducts and lobules. The lobules sort of make the milk, and then the milk is pushed through the ducts to the nipple. If you look at the duct, which is that circle at the bottom, that's normal. Those are normal cells. And then for whatever reason, we see that the next slide, the second circle, there are cells that are starting to sort of proliferate or grow, and then they continue to grow and then continue to grow. And that progression goes from normal to not normal. And in between there, you have what we call atypical hyperplasia, which is just high risk right there. Yep, high risk breast lesion, and we remove those, but they're not considered cancer. The next one after atypical ductal hyperplasia is ductal carcinoma in situ. So that is a cancer. And then the last one is an invasive ductal carcinoma. And that's when the cancer cells actually pass through, and you see that pass through the duct. Next slide. So the atypical ductal hyperplasia and atypical lobular hyperplasia, as well as LCIS, can increase your lifetime risk of breast cancer by 4 to 10-fold. We do biopsy these lesions, and then when we see them, we do recommend surgical excision because they are high risk. We also associate with high risk management. So I just told you that it can increase your risk of breast cancer, but there are things that we can do to decrease that risk. One thing is our hormonal therapy, where we want to decrease your estrogen, the estrogen that your body sees, as well as screening your breast and looking at it sort of closer. So instead of just the mammogram every year, sometimes we will recommend an MRI in addition to that. A radial scar is also a complex lesion that we often recommend removing, and that's surgical. It has a lower risk to turn into breast cancer. Next slide. So I talked about benign breast. Dr. Carter talked about breast cancer. And, you know, the main thing is to own the fact that if we find something, it doesn't mean that it's always bad, but it does mean that perhaps you have to do something about it. Part of breast health, or having your best health, is ensuring that you eat healthy, that you exercise, that you meditate, decrease smoking if you can, get good sleep, and go see your primary care or your breast specialist if you have any questions about your breast health. We want to have long, healthy lives. We want women to have long, healthy lives. And so that's why Dr. Carter and I do what we do, and we're out here trying to educate. So we are happy to take any questions.
I did see a question in the chat a little bit earlier that I just want to go back to. That was, how do you help people figure out what is feeding the cancer in the first place, or are we to assume the cancer is genetic? So as I mentioned, most cancers are not genetic. 9 out of 10 are going to not have any sort of genetic mutation associated with them, but that doesn't mean that there won't be a familial aspect associated with it. So when you come in and see your provider and they take your health history, they're going to ask about anyone in your family who has had breast or ovarian cancer. If there are lots of people in your family who have had breast or ovarian cancer, or if they've had it at a young age, then we'll probably recommend genetic testing, even if you don't have a cancer, okay? If you do have a cancer and you're young, under the age of about 45 or so, then we're definitely going to recommend genetic testing. But that being said, we are assuming baseline that your genetics don't have anything to do with your cancer. When we find out that it does, if we find out that it does, then we will treat appropriately with the extra things that might be contributing to your cancer. But baseline, we're going to assume that it is not a genetic problem. We're going to assume that this is what we call a spontaneous cancer that just developed over years of your cells turning over. And then all of a sudden your cells had it's sort of a accumulation of problems that your cells have that lead to that picture that Dr. B showed us that shows the progression to a cancer. That just happens because cells are turning over so quickly and so often that sometimes they make mistakes. And that's how you get to that point.
Absolutely. And I think just to drive home what you were saying, because we often hear it in the community that, well, my family they don't have breast cancer. Breast cancer doesn't run in my family, so maybe I don't need to get a mammogram. And that's absolutely not true. Again, the majority of breast cancers are not associated with a genetic mutation. So just sort of remember that and remain vigilant in getting your mammogram. And I should also just piggyback off of that, because we are seeing that in this year, because of COVID, women are not going to get their mammograms like they were, and that's based on fear and other reasons. But as Dr. Carter showed, when you get the mammogram, we're able to, the hope is that we catch the cancer at its most earliest stage. And that improves your survival. So so continue to get your mammogram despite the fact that COVID is still here.
Great, thank you guys. There was a question, Dr. B, when you were speaking about children and your when your cycle starts. I believe the question is, if you never had children, what is your risk for breast cancer?
So it's all sort of cumulative. If you don't have children, then you're just not protected for that particular sort of part. The children, when you're pregnant, your hormones sort of, remember we talked about sort of the exposure of hormones, it changes and it actually is protective. So if you don't have children, it doesn't mean you're going to get cancer, breast cancer, but you didn't get that protection. And then I think there was a question about secondhand smoke. Yeah, so secondhand smoke absolutely, is not good. It's not good, just like smoking is not good. So try to limit secondhand smoke.
Great. And then there was a follow-up question, I guess, to pregnancy. You mentioned that at a later age, a first pregnancy, it puts you at higher risk. Why is that?
It doesn't put you at a higher risk, but having children at a younger age actually protects you. But having a child at an older age is not a higher risk. So and then also the more children that you have also is protective. So I always laugh and say that our grandparents knew what they were doing. I have 5 aunts and uncles, and and I'm one of 7. So, it's not really current day practice. And I'm not saying go have a bunch of children. But the other thing to consider is when you're pregnant or when you have a baby, then you also have the opportunity to, some women have the opportunity to breastfeed, and that also is protective. Do you have anything to add?
There's
I agree with what you said.
There are a lot of questions coming through, so we'll do our best to get through as many as we can. There is a question here about if you've had a lumpectomy or radiation, how can a breast self-exam help you?
So it's still going to help you because you are the one that knows your breast best. If you had a lumpectomy and radiation, you should have seen your providers after you finished and in follow-up in the next few years, and they can tell you sort of the normal changes to your breast. So your breast color may change after radiation, your skin may change after radiation to be a little bit thicker or harder, might be the way that you describe how it feels. And some of those changes are very normal. But you'll get used to the changes that you've had that your providers tell you are normal, and you'll notice if things are different than what those changes were. I always tell my patients, you're the ones that are going to know your breast the best. You see them every day. I only see you once every 3, 6 months, a year, however often you're coming to see me. I can see big changes that happen, but if there's something little that's different after your lumpectomy, and you're not sure about it, it is okay to just go and get that checked because you're not sure. I can't tell you specifically what changes you might be looking at after you've had these changes from treatment, but know that if you're not sure, it's always okay to come get it checked with your specialist.
Great. Anything to add, Dr. B?
I agree 100%, Dr. Carter.
There is a question about racial disparities in breast cancer survival. What are the racial disparities for survival?
So when I showed you the overall numbers of a 99% survival rate at in a stage 1 cancer, so in a localized cancer, there is a difference when we look at our white females in the US compared to African-American females. So that percentage of survival is a little bit lower in Black women, which is why it is important that we treat these at their earliest stage. And we don't know all of the facts as to why that survival is different, but we do know that the sooner that someone is diagnosed and the sooner we get them to treatment, the better that they do as far as their overall survival. And that difference stays, we see that difference no matter what stage you're in. So whereas 99% of women survive 5 years in a localized stage and 86 in a regional stage, that number for African-American women is a little bit lower again in the regional stage and then lower again in the metastatic stage.
Okay. There is a question, after a mastectomy, can someone get cancer again?
So the answer is yes, you can get cancer again. And what I often tell patients is a mastectomy doesn't completely take away your risk of developing breast cancer, but it absolutely reduces the risk. But there is no way to remove 100% of your breast tissue. We removed a majority. So those remaining breast cells should be checked. And so we often will do the breast checks when you come and visit us, and we continue to tell you to check your breast as well. But yes, you can develop breast cancer after a mastectomy. It's rare, but it can happen.
Okay, thank you. We have time for about one more question. We have a poll that we'd like you guys to do, and also we have a winner of our raffle. This question is, the person is in their late 30s and you recommend screening at age 40. Can she get checked out to be on the safe side, or should she wait 2 years until she turns 40?
I think you probably are not going to benefit from a mammogram at this point, not knowing your full history. But that doesn't mean that there's no way to be checked. So again, don't forget to do your self-breast exams, but also you can see your primary care or your gynecologist who will do a breast exam on you if you ask them to.
Okay. What are the challenges with dense breasts if there's a self-exam or a mammogram on ultrasound? What are the challenges with dense breast?
Yeah, so dense breasts is challenging, especially. So I'll start with just a self breast exam. It may feel rocky, and it's difficult for you to determine whether that's abnormal or not abnormal or normal. But again, it goes back to if you learn your breast, despite the fact that you may have dense breast, when something does present itself, then you're more likely to catch it. As it relates to mammography, I think about a mammogram like a chalkboard, the old school chalkboard. When we take a picture of the chalkboard, that's what you see. That's someone who has fatty breast. If I wrote on that chalkboard with a bunch of white chalk, just covered the whole chalkboard up, that's dense breast. The issue is cancers are like salt or snow that you throw against the chalkboard. If I throw the snow against the chalkboard and there's a bunch of writing on it with white chalk, it's difficult to see. If I throw the chalk on the blackboard and there's not a lot of writing, then it's easier to see. So dense breast is harder to see the cancers. The ultrasound then comes into play because it's a different way of looking at the breast. It's not the chalkboard. It's sort of like apples and oranges. And when you put the two pieces together, you can have a better idea of what's going on. And so that's the challenge. And it's also a challenge of getting the ultrasound and making sure that if you have dense breast, advocate for yourself in getting that ultrasound.
So just a follow-up question about the dense breast, because I get that question a lot. If a person has dense breast, does that make them more at risk for breast cancer? I'm sorry if you answered that.
No, I didn't answer. So it doesn't, there's sort of studies that sort of go against themselves, but for the most part, it does not increase the risk. The way I look at it is it's harder to find the cancer. And then there's sort of an argument that because you have dense breast, there's more breast tissue there. So therefore there's an increased risk. So that's where that argument comes from. I don't sort of lean on that. I sort of think about it like it's difficult to find. And so as a result, you need to ensure that you get the mammo and ultrasound. Again, 50% of women have some form of dense breast. So are they at an increased risk of developing breast cancer? Who knows, but let's continue to do the mammo and ultrasound to just check it vigilantly.
Great, thank you. So one last question, and then I'm going to talk about a survey we have going on, and Frances will talk about a poll, and then I'll announce our winner. So stay with us, people. Thank you so much. The last question is, if you have implants, what does that mean for your risk for breast cancer, breast implants?
Breast implants don't change your risk for breast cancer itself. There is a little bit different what they do as far as the protocol for your imaging if you have breast implants to make sure that we can see your whole breast the way that we're supposed to, because it does change the ability to image your breast, but we can still accurately image your breast and get the pictures we need to make sure that you're screened appropriately. There are other things associated with breast implants, illness-wise, and some of the specific types of implants that are associated with that have been taken off the market at this point. So it doesn't change the fact that you should be doing your screening, that you should be doing your self-breast exams, and that you should be aware of your breast.
Great, thank you. Thank you guys for that informative conversation, and thank you all for your questions. When you register, we provided an email list. If you want to share more questions that we weren't able to get to, please do. On the screen now, we have a poll. We'd like just to get your opinion on what the presentation, has it helped you? Was it clear? Just things of that nature. Additionally, we have a survey. We'd like to let your voice be heard. It's a Sister Give Me Your Hand survey. It's for African-American women in Brooklyn, New York, and Camden City or surrounding areas. The survey allows us to find out information about breast cancer screening behaviors for African-American women. The goal is simply in line with this, the purpose of this whole talk is we really want to increase awareness, education, and screening of breast cancer for African-American women. If you participate in the survey, you can receive a $20 gift card. It takes about 25 minutes to complete the survey. To participate in the survey, you must be African-American. You have to be 40 years of age or older, and you cannot be a breast cancer survivor. The women who live in Brooklyn, New York, or Camden City, New Jersey, and in Camden, we are accepting people from surrounding areas can participate. If you scan this barcode right now, it will take you to the survey link in Camden City, and you'll fill out information and we'll get back to you. If you could just, we'll try to put this one in the chat so that you can be able to just click it and go to the survey. Well, not the survey, to the page that allows you to register to take the survey. The survey is administered by one of our staff persons. So again, it takes about 20-25 minutes. You have to be African-American or identify as Black, 40 years of age or older, and you cannot be a breast cancer survivor. So that's the survey. And right now we have a poll going up. And again, thank you guys for your participation. We're glad you were able to spend, spend this Thursday evening with us. We truly appreciate it. And are we?
I do have a question. So to scan, I just want to make sure we understand. So for the survey, if you are 40 or older, Black,
yes.
You live in Brooklyn or Camden, New Jersey, correct?
Yes.
Then you can take out your phone. These code things are so new, but it's on every, if you go to restaurants now. And so you take out your phone and you just hold it up to the screen.
Yes.
And then it will take, and every person who completes the survey, so you'll call them, they'll complete the survey on the phone, someone, and then they get a $20 gift card. Is that correct?
Yes, yes. And so the barcode scan or the QR code will take you to the Camden site. If you cut and paste this in your, sorry, my computer's acting crazy. This will take you to the New York location, to the New York survey.
So they have to type in for the New York one, bit.ly?
Frances did put it in the chat, so you can just click on it in the chat right now if, to go to the New York one.
Click on the link in the chat. Got it.
And if you're in New Jersey, scan the code. Thank you. Okay, so there's a couple more people still completing the poll. Again, we thank you for participating. And before I announce the winner, Frances, is there anything else you want to add before we close?
I just want to say thank you, everyone, for joining us tonight. Thank you so much, Dr. Carter and Dr. Bea.
Yes.
I think everyone can agree that we've learned a lot. And again, please, if you haven't, fill out the poll.